Welcome to Ravel's 2021 Evaluation and Management Leveling Guidelines. Hi, I'm Marie Moss, the coding educator for Ravel with 30 years in healthcare coding, 5 of it being with Ravel. I love the outdoors and I reside near St. Louis, Missouri, so therefore I am a Cardinal fan. Our agenda for today is history and examination, time, office visit and other outpatient services code description, medical decision making, prolonged services, and fee rate impact. As of January 1st of 2021, it will no longer be required to use history and examination to level an office visit outpatient service evaluation and management code 99201 to 99215. Although it is not needed to level the codes, however, it is highly recommended to continue documenting a medically appropriate history and examination. January 1st of 2019, CMS expanded the policy for office or outpatient evaluation and management visits to provide that any part of the chief complaint or history that is recorded in the medical record by ancillary staff or the beneficiary does not need to be redocumented by the billing practitioner. The billing practitioner can review the information, update or supplement it as necessary, and indicate in the medical record that he or she has done so by signing and dating. This applies to the chief complaint and any other part of the history, such as history of present illness, past family social history, or review of systems for new and established office or outpatient evaluation management visits. The ancillary staff consist of residents, medical assistants, etc. Come January 1st of 2021, here are the new changes for the evaluation and management guidelines. First, counseling and/or coordination of care no longer has to dominate the service for leveling an E&M code by time. Total time on the date of the encounter includes both the face-to-face and non-face-to-face time personally spent by the physician and/or other qualified healthcare professionals. Hence the bold print for total time on the date of the encounter. We will learn more about this on the next slide. Another guideline is the physician or other qualified healthcare professionals' time is spent in the supervision of clinical staff who perform the face-to-face services of the encounter. Use code 99211. Currently, the description for the code 99211 is office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. Usually the presenting problem or problems are minimal. Typically 5 minutes are spent performing or supervising these services. The new descriptor of 99211 gives clarity of the individuals performing the services, being the clinical staff, and no time will be associated with the code. Another guideline is for shared or split visits, in which you'll select the appropriate level of a service for which time-based reporting spent by the physician and other qualified healthcare professional or professionals assessing and managing the patient on the date of the encounter is summed to define total time. When 2 or more physicians and other qualified healthcare professionals need to discuss the patient, only the time of one individual should be counted. And the last new guideline is when prolonged time occurs, the appropriate add-on code may be reported. The appropriate time should be documented in the medical record when it is used as the basis for code selection. A new prolonged service code is being created and revisions are being made to existing prolonged service codes to meet the evaluation and management time changes. For 2021, time may be used to select a code level in office or other outpatient services for codes 99202 through 99205 and 99212 through 99215, whether or not counseling and/or coordination of care dominates the service. You will still need to use the old time rule for other evaluation and management services when counseling and/or coordination of care dominates the service by 50% of the total time of the encounter. Total time spent on the day of the encounter can include preparing to see the patient, such as reviewing of tests, obtaining and/or reviewing separately obtained history, performing a medically appropriate examination and/or evaluation, counseling and educating the patient, family, and/or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals when they are not reported separately, documenting clinical information in the electronic or other health record, independently interpreting results when they are not separately reported, and communicating results to the patient, family, and/or caregiver, and last, care coordination when it's not separately reported. Total time on the date of the encounter for office and other outpatient services includes both the face-to-face and non-face-to-face time personally spent by the physician and/or other qualified healthcare professionals. When the physician or other qualified healthcare professionals' time is spent in the supervision of clinical staff who perform the face-to-face services of the encounter, you'll use code 99211. Counting clinical staff time is not allowed for such as taking the patient's vitals. However, the time for the provider to review the vitals will be accounted for in the provider's total time. What would be considered as bad timing is when the physician or other qualified healthcare providers waits until the day after or beyond an encounter to enter the clinical information into the patient's medical record. That time cannot be counted towards the visit because it did not occur on the day of the encounter. If the provider orders and interprets a test or X-ray, this cannot be accounted for time due to the time is included in the test or X-ray procedural charge. The 2021 time changes are, hence there's no allowed time for 99201 since that code is going to be deleted. Established office visit codes are in 9-minute increments, and the new office visit codes are in 14-minute increments. The exact ranges will remove the use of a midpoint. Time beyond the allotted amount of level 5 codes, 99215 or 99205, will be considered as prolonged services, in which we will learn further in the presentation. Note that 99215 time ends at 54 minutes and 99205 time ends at 74 minutes. So let's practice leveling by time. Dr. Jones sees an established patient today. Prior to the visit, Dr. Jones reviewed the patient's medical record due to patient's obesity issues for 7 minutes. During the visit, the doctor performed an examination of her knees due to complaint of knee pain requiring 4 minutes. He prescribed her meloxicam 7.5 milligram and completed the documentation, taking about 3 minutes. We can count the 7 minutes for reviewing the medical record, 4 minutes for the exam, and 3 minutes for prescribing and documenting, equaling a total of 14 minutes. Therefore, the CPT code would be 99212. Medical decision making. CPT code 99201 will be deleted from the office visit outpatient services. Please do not delete from the client's data set, for it has a history. The reason it will be removed for it is it shared the same medical decision-making level as 99202, straightforward. New descriptors for the new patient evaluation and management codes. 99202 is an office or other outpatient visit for the evaluation and management of a new patient, which requires a medically appropriate history and/or examination and straightforward medical decision-making. When using time for code selection, 15 to 29 minutes of total time is spent on the date of the encounter. 99203 is also an office and other outpatient visit for evaluation and management of a new patient, which requires a medically appropriate history and/or examination and a low level of medical decision making. When using time for code selection, 30 to 44 minutes of total time is spent on the date of the encounter. 99204, office and other outpatient visit for evaluation and management of a new patient, which requires a medically appropriate history and/or examination and moderate level of medical decision making. When using time for code selection, 45 to 59 minutes of total time is spent on the date of the encounter. And last, 99205 for the new patient office and other outpatient codes, which requires a medically appropriate history and/or examination and a high level of medical decision making. When using time for code selection, 60 to 74 minutes of total time is spent on the date of the encounter. For services of 75 minutes or longer, see prolonged services 9XXX, which we will learn further into the presentation. For the descriptors of the established patient, 99211 for office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. Usually the presenting problems are minimal. Office or other outpatient visit for the evaluation and management of an established patient of a 99212, which requires a medically appropriate history and/or examination and straightforward medical decision-making. When using time for code selection, 10 to 19 minutes of total time is spent on the date of the encounter. A 99213 is office or other outpatient visit for the evaluation and management of an established patient, which requires a medically appropriate history and examination and a low level of medical decision making, with a time of 20 to 29 minutes for total time spent on the date of the encounter. For 99214 is also for an office or an outpatient visit for an E&M services of an established patient, and this is for a medically appropriate history and/or examination and of a moderate level of a medical decision making, with a time of 30 to 39 minutes. And last is a 99215 for an office or other outpatient visit for evaluation and management of an established patient, which requires a medically appropriate history and/or examination and a high level of medical decision making, When using time for code selection, 40 to 54 minutes of total time is spent on the date of the encounter. For services of 55 minutes or longer, you'll use the prolonged code service 99XXX, which currently has not been determined yet. It is in the proposed stage, and hopefully we'll know something here within the next couple of weeks. So notice that for each of the visits, excluding 99211, for both new and established E&M codes, it requires a medically appropriate history and/or examination, although you will not be leveling by those no longer. So here we have a short descriptor of the office visit outpatient services codes. And as you can see, it's just broken down by code and giving you the appropriate minutes. This might be something that we may be in consideration of using the short descriptors for the client's data set. But notice here for the 99211, which is a minimal medical decision making, and there's no time that is involved with this code. And also the minimal nurse status would be an RN. So for the summary of what we have learned, the 2021 E&M guidelines changes pertain to new and established office or outpatient visits only, cannot level with history or examination components, but can document and should document and highly recommended to do so, and the removal of 99201 from the office visit outpatient visits due to it shares the same medical decision level as a 99202, being straightforward. Here are the new elements of the medical decision making. Number of complexity of problem addressed. Therefore, diagnosis will need to reflect the complexity or those complexities. Amount and/or complexity of data to be reviewed and analyzed. And the risk of complications and/or morbidity or mortality of patient management. Note, the CPT code 99211 does not have any elements. Remember, this is when the physician or other qualified healthcare professionals' time is spent in the supervision of clinical staff who perform the face-to-face services of the encounter. The next level is 99202 and 99212. It requires a straightforward medical decision making and will need 2 of the 3 components. Here's 1, 2, or 3 components. It's a minimal of 1 self-limited or minor problem, or a minimal or no amount and/or complexity of data to be reviewed and analyzed, and/or minimal risk of morbidity from additional diagnostic testing or treatment. In the third column of the Evaluation and Management Medical Decision-Making chart, there was provided in the invitation number and complexity of the problem addressed, which is a problem is addressed or managed when it is evaluated or treated at the encounter by the physician or other qualified healthcare professional reporting the service. This includes consideration of further testing or treatment that may not be elected by virtue or of risk, benefit analysis, or patient, parent, guardian, surrogate choice, notation in the patient's medical record that another professional is managing the problem without additional assessment or care coordination documented does not qualify as being addressed or managed by the physician or other qualified healthcare professional reporting this service. Referral without evaluation by history, exam, or diagnostic study or studies, or consideration of treatment does not qualify as being addressed or managed by the physician or other qualified healthcare professional reporting this service. For the CPT codes 99202 and 99212, medical decision making of the third column, you have two terminologies. One is minimal problem, which is a problem that may not require the presence of the physician or other qualified healthcare professional, but the service is provided under the physician or other qualified healthcare professional supervision. And then you should use code 9211. Another medical term is self-limited or minor problem, which is a problem that runs a definite or prescribed course, is transient in nature, and is not likely to permanently alter health status. Here are the components for levels 99203 through 99213. For the number of complexity of problems addressed is low, this being two or more self-limited or minor problems, or one stable chronic illness, or one acute uncomplicated illness or injury. This is why it's going to be very important for our providers to start using these terms, chronic and acute. For the component of amount and or complexity of data to be reviewed and analyzed, for this level would be limited. It must meet the requirements of at least one of the two categories. Category 1 would be test and documents. This would be any combination of two of the following. One would be review of a prior external note or notes from a unique source. Another would be review of the result or results of each unique test. And last would be ordering of each unique test. Or category 2 would be an assessment requiring an independent historian or historians. For the categories of an independent interpretation of tests and discussion of management or test interpretation, then you would see moderate or high level. And the last component being risk of complications and or morbidity or mortality of patient management would be a low risk of morbidity from additional diagnostic testing or treatment. For the medical terms for this level would be stable chronic illnesses, which could be a chronic problem with an expected duration of at least a year or until the death of the patient. This could be a chronic problem as whether or not the stage or severity changes. An example would be uncontrolled diabetes, and uncontrolled diabetes are a single chronic condition. Another stable or chronic illness could be like a patient that is not at their treatment goal of their chronic illness, is not considered stable. And this could be an example as a patient with persistently poorly controlled blood pressure, for whom better control is a goal, is not stable, even if the pressures are not changing and the patient is asymptomatic. And another stable chronic illness is the risk of morbidity without treatment is significant. An example would be a patient with well-controlled hypertension or non-insulin dependent diabetes or cataract or benign prostatic hyperplasia. For the same level, the terminology for acute or uncomplicated illness or injury could be a recent or a new short-term problem with low risk of morbidity for which treatment is considered, or there is a little to no risk of mortality with treatment, and full recovery without functional impairment is expected, or a problem that is normally self-limited or minor, but is not resolving consistent with a definite or prescribed course as an acute uncomplicated illness. An example could be like a cystitis, allergic rhinitis, or a simple sprain. For the fourth level, being of 99204 through 992 and 99214, this is considered the moderate level. For the number of complexity or problems addressed, could be one or more chronic illnesses with exacerbation, progression, or side effects of treatment, or two or more stable chronic illnesses, or one undiagnosed new problem with uncertain prognosis, or one acute illness with systemic symptoms, or one acute complicated injury. For the amount and/or complexity of data to be reviewed and analyzed, which must meet the requirements of one out of the three categories. Category 1 would be test documents or independent historians. And this can be any combination of the following. One would be a review of a prior external note or notes for each unique source, or a review of the results of each unique test, or ordering of each unique test, or assessing requiring an independent historian or historians, or category 2 being of an independent interpretation of test. This could be an independent interpretation of a test performed by another physician or other qualified healthcare professional, but it cannot be separately reported. And the last category be category 3. This could be a discussion of management or test interpretation. This would be with an external physician or other qualified healthcare professional or appropriate source, and it cannot be separately reported in another procedure. And the last would be the risk of complications and/or morbidity or mortality of patient management in this level. This would be of moderate risk. And examples would be prescription of drug management, decision regarding minor surgery with identified patient or procedure risk factors, or a decision regarding elective major surgery without identified patient or procedure risk factors, or a diagnosis or treatment significantly limited by social determinants of health. Social determinants of health are the poor health outcomes that are often made worse by the interaction between individuals and their social and physical environment. An example would be in counties where ozone pollution is high, there is often a higher prevalence of asthma in both adults and children compared with state and national averages. Poor air quality can worsen asthma symptoms, especially in children. So for some of the definitions for the fourth level, codes 99204 and 99214, would be the chronic illness with exacerbation, progression, or side effects of treatment. This could be a chronic illness that is acutely worsening, poorly controlled, or progressing with an intent to control progression and requiring additional supportive care, or requiring attention to treatment for side effects, but that does not require consideration of hospital level of care. For undiagnosed new problem with uncertain prognosis, this could be a problem in the differential diagnosis that represents a condition likely to result in a high risk of morbidity without treatment. An example might be a lump in the breast. For an acute illness with systemic symptoms, this can be an illness that causes systemic symptoms and has a high risk of morbidity without treatment. For systemic general symptoms such as fever, body aches, or fatigue in a minor illness that may be treated to alleviate symptoms, shorten the course of illness, or to prevent complications, see the definitions for self-limited or minor or acute uncomplicated. Systemic symptoms may not be general, but they may be of a single system. Examples may include pyelonephritis, pneumonitis, or colitis. For acute complicated injury, which is an injury which requires treatment that includes elevation or evaluation of body symptoms that are not directly part of the injured organ, the injury is extensive, or the treatment options are multiple and or associated with risk of morbidity. An example may be a head injury with a brief loss of consciousness. Social determinants of health conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. To be the availability of resources to meet daily needs, such as safe housing and local food markets, access to educational, economic, and job opportunities, access to healthcare services, quality of education and job training, availability of community-based resources, and support of community living and opportunities for recreational and leisure time activities, transportation options, public safety, social support, social norms and attitudes such as discrimination, racism, and distrust of government, exposure to crime, violence, and social disorder, such as presence of trash and lack of cooperation in a community, socioeconomic conditions, such as concentrated poverty and the stressful conditions that accompany it, residential segregation, language literacy, access to mass media and emerging technologies, such as cell phones, the internet, social media, and culture. In order to level by a social determinant of health, the provider should document the question or questions asked and the response. For a possible question in regards to patients who are 12 months and younger, Bright Future, as you can see the hyperlink below, see pages 4 and 5. So some sample questions would be, tell me about your living situation. Do you have enough heat, hot water, electricity? Do you have appliances that work? Do you have problems with bugs, rodents, peeling paint or plaster, or mold or dampness? How are your resources for caring for your child? Do you have enough knowledge to feel comfortable for caring for her? Do you have health insurance? Do you have enough money for food, clothing, and childcare? Within the past 12 months, were you ever worried whether your food would run out before you got money to buy more? Within the past 12 months, did the food you bought not last and you did not have enough money to get more? Have you ever tried to get help for these issues? What happened? What barriers did you face? Each social determinant of health should have an anticipatory guidance. An example of an anticipatory guidance for the above questions could be, if you have problems with any of these things, let me know, and I can tell you about community services or and others resources that can help you. This would be appropriate documentation in order to level for this. As state Medicaid programs transform their delivery systems to improve health and control costs, they have increasingly focused on the role that social determinants play in the health of their enrollees. Some states are using existing state administrative data sources to gather social determinants of health information rather than screen individuals through patient level data collection. Massachusetts, for example, created a neighborhood stress index that determines the degree to which individuals' environment affects their own health outcomes and incorporated the index into. These screenings and administrative data initiatives can be valuable components for the overall social determinant of health strategy by helping identify enrollees at high social risk and as a first step to linking enrollees to needed social services. And here is a hyperlink of some of the state requirements. Social determinants of health are conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect the range of health and functioning and the quality of life outcomes of risk. Here are the diagnostic category codes. Z55 for problems related to education and literacy. Z56, problems related to employment and unemployment. Z57 is occupational exposure to risk factors such as exposure to radiation, dust, and other contaminants, extreme temperature. Z59 is problems related to housing and economic circumstances. Z60, problems related to social environment, such as living alone, adjustment to retirement, migration, discrimination. Z62 is problems related to upbringing. Z63 is other problems related to primary support group, including family circumstances. Z64 is problems related to certain psychosocial circumstances, such as unwanted pregnancy, discord with probation officer. Z65 are problems related to other psychosocial circumstances. Here we have added a couple of hyperlinks of the different types of health information as it pertains to the social determinants of health. Last is the level 5 codes, 99205 and 99215. These are a high medical decision making. It's also a high number of complexity of problems addressed, and that would be one or more chronic illnesses with severe exacerbation, progression, or side effects of treatment, or one acute or chronic illness or injury that poses a threat to life or bodily function. For the amount and or complexity of data to be reviewed and analyzed is extensive, which must meet the requirements of 2 out of the 3 categories. Category 1 is for test documents and independent historians. Any combination of the 3 of the following would be a review of prior external note or notes from each unique source, review of the result or results of each unique test, ordering of each unique test, and or assessment requiring an independent historian or historians. For category 2, this is for independent interpretation of tests. This can be performed by another physician or qualified healthcare professionals, but cannot be reported separately. Or category 3 for discussion of management or test interpretation. This is with an external physician or other qualified healthcare professional or appropriate source, but cannot be separately reported by other procedural codes. And for the risk of complications and or morbidity or mortality of patient management, it is a high risk. And examples would be like drug therapy requiring extensive monitoring for toxicity, Decision regarding elective major surgery with identified patient or procedural risk factors. Decision regarding emergency major surgery. Decision regarding hospitalization. Decision not to resuscitate or to de-escalate the care because of poor diagnosis. And to understand this level of 99205 and 99215 medical decision making, chronic illness with a severe exacerbation, progression, or side effects of treatment. This could be of a chronic illness or a severe side effects of treatment that have significant risk of morbidity and may require hospital level of care. For acute or chronic illness or injury that poses a threat to life or bodily function. This can be in the near term without treatment. And examples may include acute myocardial infarction, pulmonary embolus, severe respiratory distress, progressive severe rheumatoid arthritis, psychiatric illness with potential threat to self or others, peritonitis, acute renal failure, or an abrupt change in neurologic status. For other medical decision-making terminology, what it means by test. This is tests for imaging, laboratory, psychometric, or psychologic data. A clinical laboratory panel, such as a basic metabolic panel 80047, is considered a single test. The differentiation between single or multiple unique tests is defined in accordance with the CPT code set. For external, this means external records, communication, and/or test results, which are from an external physician, other qualified healthcare professional, facility, or healthcare organization. For the determination of external physician or other qualified healthcare professional, this is an individual who is not in the same group practice or is a different specialty or subspecialty. It includes licensed professionals that are practicing independently. It may also be a facility or organizational provider, such as a hospital, nursing facility, or home health care agency. An independent historian or historians are individuals such as parents, guardians, surrogate, spouse, witness, who provides a history in addition to a history provided by the patient who is unable to provide a complete or reliable history. And this could be like due to developmental stage or dementia or psychosis, or because a confirmatory history is judged to be necessary. In the case where there may be a conflict or poor communication between multiple historians and more than one historian is needed, the independent historian requirement is met. For an independent interpretation, this is of a test for which there is a CPT code, and an interpretation or report is customary. This does not apply when the physician or other qualified healthcare professional is reporting the service or has previously reported the service for the patient. A form of interpretation should be documented, but not conform to the usual standards of a complete report for the test. An appropriate source, this is for the purpose of the discussion of management data element. An appropriate source includes professionals who are not healthcare professionals, but must be involved in the management of a patient, such as a lawyer, a parole officer, case manager, teacher. It does not include discussion with family or informal caregivers. The terminology for risk is the probability and/or consequences of an event. The assessment of the level of risk is affected by the nature of the event under consideration. For an example, a low probability of death may be a high risk, whereas a high chance of a minor or self-limited adverse effect of treatment may be low risk. Definitions of risk are based upon the usual behavior and thought processes of a physician or other qualified healthcare professional in the same specialty. Trained clinicians apply common language usage meanings to terms such as high, medium, low, or minimal risk, and do not require quantifications of these definitions, though quantification may be provided when evidence-based medicine has established probabilities. For the purposes of medical decision-making, level of risk is based upon consequences of the problem or problems addressed at the encounter when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, and/or hospitalization. Morbidity is a state of illness or functional impairment that is expected to be of substantial duration during which function is limited, quality of life is impaired, or there is an organ damage that may not be transient despite treatment. And as we've learned, social determinants of health, this is the economic or social conditions that influence the health of people and communities, such as food and housing insecurities. Also for the 992 or the fifth level, the drug therapy requiring intensive monitoring for toxicity. This could be a drug that requires intensive monitoring, is a therapeutic agent that has the potential to cause serious morbidity or death. It also could be the monitoring is performed for assessment of these adverse effects and not primarily for assessment of therapeutic efficacy. Also could mean the monitoring should be that which is generally accepted practice for the agent, but may be patient-specific in some cases. Also could be intensive monitoring, may be long-term or short-term. Long-term intensive monitoring is not less than quarterly. The monitoring may be by a lab test or psychologic test or imaging. Monitoring by history or examination does not qualify. The monitoring affects the level of medical decision-making in an encounter in which it is considered in the management of the patient. Examples may include monitoring for cytopenia in the use of an anti-neoplastic agent between dose cycles, or the short-term intensive monitoring of electrolytes and renal function in a patient who is undergoing diuresis. Examples of monitoring that does not qualify include monitoring glucose levels during insulin therapy, as the primary reason is the therapeutic effect, even if the hypoglycemia is a concern, or an annual electrolytes and renal function for a patient on a diuretic as the frequency does not meet the threshold. With each of the medical decision-making levels, you'll need at least 2 out of the 3 elements. Here in this case, for the third level, as you can see, for the number of complexity of problems addressed. For example, if the patient had one acute uncomplicated illness or injury, and for the risk of complications and/or morbidity or mortality of patient management, if it was a low risk of morbidity from additional diagnostic testing or treatment, then you would code it out as a 99203 or 99213 according to the patient's status. In this chart, we can see the proposed 2021 fee schedule rate for new patient and established patient. With the work of the COVID, CMS is delaying the final rule. It may be released as late as December 1st of 2020. Levels 2 through 4 will be the same fee. for both new and established. Therefore, there will be increases and a decrease. So increases with the second and third level and a decrease with the fourth level. For the fifth level, there will be a slight increase, such as for 99205, which is currently payment rate is $210. The 2021 proposed rate will be $212. So let's look at some examples of a typical revenue chart of a given month. So here you can see for 99211, we have 0 claims. For 99212, we have 3 claims averaging $138. For 2021, that would equal $270, therefore being an increase of $132. For 99213, if we had 135 claims equaling current or for 2019, $10,125. As it is proposed for 2021, we'd make it $12,150. Therefore, with it having a profit of $2,025. If there were 402 claims for 99214, would be the rate for 2019 of $44,220. For the proposed rate of 2021 would be $36,180, with a difference of $8,050 being a loss. And with 21 claims for level 299 or for code 99215, for the revenue rate for 2019 being $3,108, and for the proposed rate of 2021, $3,129, with an increase of $21. So in overall, you can see it would be a total loss of $5,872. If we were just to move some numbers around for the amount of claims, as you can see for the third and fourth levels, just interchanging those two numbers and claims gives you a profit of $3,483. Once again, if you were to move the numbers again, this time for the third, fourth, and fifth levels, making it 21 claims for the third level, giving you an increase of $315. For the fourth level codes, 402 claims would give you a loss of $8,050. And for the fifth level, increasing it to 135 claims would give you a slight difference of $135, with an overall loss of $7,468. So with that, they have come up with the prolonged services just for these codes for the office visit and outpatient services, which we're going to still be able to use the old prolonged services, but there's going to be a new one now for the to help out with the new 2021 code changes. So here we have 99354 and 99355. All of these are add-on codes, but you can see they are separated by types of services, whether it be office or other outpatient services, or inpatient or observation services, or settings, I'm sorry, in settings versus services. And this is whether it's the first hour or each additional 30 minutes. And as you can see too, we are currently our 2020 non-facility rates for these types of services. And currently, these are added on to codes 99202 through 99215 for the 99354 and 355 would additionally be added on. And then for the 99356 and 99357, these would be for inpatient and observation setting codes. Here we have the 99358. I'm sorry, that's supposed to be an add-on code. And 99359. These are for before and or after direct patient care for the first hour and each additional 30 minutes. And also you have the 99415 and 416. These are for prolonged clinical staff services during an evaluation and management services in the office or outpatient setting with direct patient contact with physician supervision, first hour, and each additional 30 minutes. The 99415 and 99416 can be coded in conjunctions with 99202 through 99205 and 99211 through 99215. 99416 can only be coded in conjunction with 99415. Codes 99415, 99416 are used when a prolonged evaluation and management service is provided in the office or outpatient setting that involves prolonged clinical staff face-to-face time beyond the typical face-to-face time of the evaluation and management services as stated in the code description. The physician or qualified healthcare professional is present to provide direct supervision of the clinical staff. The time spent by the clinical staff does not have to be continuous on the day of the office visit or outpatient evaluation management services. Time spent performing separately reported services other than E&M service is not counted toward the prolonged services time. Code 99415 is used to report the first hour of prolonged clinical service or clinical staff service on a given date. Prolonged service of less than 45 minutes total duration on a given date is not separately reported because the clinical staff time involved is included in the E&M codes. The typical face-to-face time of the primary service is used in defining when prolonged service time begins. For an example, prolonged clinical staff services for 99214 begins after 25 minutes, and 99415 is not reported until at least 70 minutes total face-to-face clinical time has been performed. When face-to-face time is non-continuous, use only the face-to-face time provided to the patient by the clinical staff. Code 99416 is used to report each additional 30 minutes of a prolonged clinical staff service beyond the first hour. Code 99416 may also be reported or used to report the final 15 to 30 minutes of prolonged service on a given day. Prolonged service of less than 15 minutes beyond the first hour or less than 15 minutes beyond the final 30 minutes is not reported separately. Codes 99415 and 99416 may be reported for no more than 2 simultaneous patients. The use of the time-based add-on codes require that the primary evaluation and management service has a typical or specified time published in the CPT code set. For prolonged services by the physician or other qualified healthcare professionals, see codes 99354, 99355, and the new code 99XXX. Do not report 99415, 99416 with 99354 or 99355 or 99XXX, and facilities may not report 99415 or 99416 codes. So here is the new code, not quite complete yet, but here is the information on it. This is a prolonged office and other outpatient evaluation and management service or services beyond the total time of the primary procedure, which has been selected using total time, requiring total time with or without direct patient contact beyond the usual service on the date of the primary service, each 15 minutes, lists separately in addition to codes 99205 or 99215 for office or other outpatient evaluation and management services. Do not report code 9XXX in conjunction with 99354, 355, 358, 359, 415, or 416. And do not report code 99XXX for any time unit unless less than 15 minutes. So here's a chart for the prolonged services with or without direct patient contact on the date of an office or other outpatient services. So if the total duration of the new patient office or other outpatient services using the code 99205, if it's less than 75 minutes, you would only just code the 99205. If it's between 75 and 89 minutes, you'll use 99205 one time, and then you'll use the 99XXX one time. And then as you can see, for the 90 to 104 minutes, you'll use the 99205 one time, and you'll use the 99XXX two times. For 105 or more minutes, you'll use 99205 one time, and you'll use the 99XXX for 3 or more for each additional 15 minutes. And the same pretty well applies for the established patient using codes 99215. For any time that it's less than 55 minutes, you would use the 99215 by itself. For 55 to 69 minutes would be 99215 used one time, and with 99XXX one time. For 70 to 84 minutes, 99215 one time, and 99XXX for 2. And for 85 minutes or more, you would use 99215 once, then 99XXX times 3 or more for each additional 15 minutes. So here we have a chart. This makes it easy to see how, by providing more services, prolonged services, and you can see such as for a new patient, maybe it was just an evaluation and management that leveled out as a 99202, and the doctor provided additional services, prolonged services, so making it by adding the 130 for the fee rate of the 99202, along with the prolonged services being of 132.09, making that flat, or that fee $262.09. Here also for the prolonged services, remember for the before and after, which equaled to $113.68. And for any of the prolonged services by the clinical staff would be $10.11. The one thing you have to remember is the physician would not be able to provide prolonged service and supervise a clinical staff simultaneously. And with that, here are the resources: American Medical Association, for the 2021 E&M Leveling. There's a couple of videos that might provide additional information. Also for the American Medical Association 2021 Prolonged Services, and for the Centers of Medicare and Medicaid Services for the 2020 Evaluation and Management Guidelines. We thank you and hope you have a good day.